So thank you everybody for coming in, and thanks for the opportunity to present. People who know me know that it's a dangerous thing to ask Paul to present on something that isn't very, very specific and needs just a few numbers, because he'll spend the day before walking in his garden thinking of things to come up with and explore. So despite Joy's best efforts of preparing many of the slides for me, I did do those, go off down rabbit holes yesterday and came up with some thoughts around Caesarean section trends and data, and how data is helpful, but then it doesn't really tell the whole story unless we really get good data. And I think that's where we're on a journey in Ireland to get there. So just very briefly, in terms of, we've seen, how much has changed in the 200 years since James Barry helped demonstrate that a mother and baby could survive a Caesarean section. And now we're no longer asking about survival from that point of view, but we're asking about how it's being used and how its use is changing, and why that is, and what does it mean, and what are the implications for mothers and babies. So that then, very briefly, going from asking the question of, can a woman survive a Caesarean section, because it was so rare that would happen for a woman in those before 1800, and then throughout the 1800s demonstrating that yes, it's possible, yes, it can be made safer, and then onto the mid 1900s, where we're talking about reducing maternal mortality and how other aspects of medical advances were able to help that situation. And then in the late 1900s, we were questioning about, well, when should Caesarean section be used? And the rates were increasing, and there was discussion around whether there was an optimal rate, and there should be a restriction on, or efforts to kind of keep it to that target of maybe 10 or 15%. And now we're at the point of asking again more questions: how, when, and for whom should Caesarean section be used? So we can look then and hopefully use better data, but again, we see sometimes that there's a limitation with that. And the word that sometimes comes up for me is variation. It's when there's too much variation, there's something that is in some ways wrong, because it doesn't usually get explained by the variation in other factors. So we can consider that in some of the slides that I'll show in a few minutes. So again, on the left-hand side is some of the issues that were kind of in the historical situation, and just often dealing with information that ultimately was coming from individual case reports. So it was very difficult to understand variation and what was influencing outcomes and things like that. And now we're looking at safety and appropriateness outcomes, where we can see how things are actually influencing outcomes and improving outcomes. But the bottom right-hand corner is where I'm really looking at different data sources that have looked at Caesarean section and can look at Caesarean section in more detail, trend analysis, patterns, and variation. So just at a high level, international Caesarean section trends, the global trend data essentially has been looked at a lot since 1990. That's where we get better data so that trends can be looked at over time. And then Anna Bertrand in the WHO published a seminal piece of work in 2016, including data from 121 countries. And one of the headline findings was really that the rate had been approximately 6.7% in 1990, but was then 19.1% in 2014. So just 25 years, we've seen a more or less almost a tripling in the Caesarean section rate. Hence, it was one of those where the trajectory would be that, well, what if it doubles, triples again in the next 25 years? But that has huge implications. So there was concerns around that, whether it was being overused, but also then within countries especially, and across countries, there's huge variation in the rates. So that suggested that some people were there was exposed to high risk of Caesarean section, and some were being deprived of the opportunity and the need for a Caesarean section. So this is one of those where if I was to give the presentation in one slide, I'd probably just give this slide and spend 20 minutes talking about it. It comes from a report that was published just this year, and looking at trends, particularly from it's produced by colleagues in the National Perinatal Epidemiology Unit in Oxford. So they were looking at the trends in England, in Caesarean section, and then they selected Western European countries and the USA to look at trends as well. Some for only about 10 years, depending on the source that they were able to get, but some going back just over 20 years. So you can see one of the things I like to talk about is that the order that the legend is in is not the order that the lines are in, or the curved lines. So it's very hard to work out which country is which. But the most important thing, I suppose, from their perspective is that England essentially had a standing out as being, with a very, very high rate. So it's in the black, and Ireland isn't in this chart, which is another thing to talk about. But we would have a similar rate, and I'll show this in a few minutes, at this time back in the early 2000s, around 25%. And you can see the gradual increase that was happening, similarly as we see for Ireland. But you can see as well, and we know this kind of curve since COVID, this isn't a linear curve. So it's accelerating in how much it's going up. In particular, you're seeing like if you were climbing a hill, and this was the hill you were climbing, this is getting very steep, and this means that this Caesarean section rate is accelerating and increasing, and is at 45%. And even their first quarterly data from 2026 suggests it's at 47%. So it's not like it's peaking and going down. It seems like it's going to hit 50% in the next year or so. And it's in contrast. Now, there are other countries that have high rates. So if they include Turkey or Bulgaria, Romania, they would be up here as well, or above. But you can see that at the lower end, then you have a cluster of countries. The 5 Nordic countries are here. Netherlands is here as well, if it was shown, but France is here. So there's some that have, they're relatively stable trends. Some have seen some decreases, like in Iceland. In Denmark here, we see some decreases. And here is quite exceptional as well, because Italy had one of the highest Caesarean section rates in Europe back in 2009. It peaked and then decreased steadily after that. So that caught my attention, and I thought I'd just look at why would that have been the case. So at a high level, we're talking about in Europe broader variation from 14% to 62%. So usually when you see something like that in any phenomenon, first thing you think is the data are too varied. So maybe they're not measuring it properly. Caesarean section is something that's relatively easy to measure, so you think that's not the case. The next thing you think, oh, it must be because the populations, the people, are much different, the patients. That feels hard to believe, that across Europe they're so different, that there's a 4-fold or 5-fold difference in their need for Caesarean section. And then you look at the process of the care. Maybe the care varies hugely across the countries as well. The lowest rates are in the Nordic countries, as I mentioned, some of the Baltic countries, and the Netherlands, about 18 to 22, 23%. Highest in Turkey, Cyprus, and then Romania and Bulgaria. So some of these questions I find it interesting, and they're put together there by Joy in terms of, look, the question is, if the maternal risk is increasing everywhere, why are the trends in some countries different than others? Can we learn from that? Why are there large within-country differences? There are huge differences within some of these countries, particularly Italy in the past had places where they had rates less than 20% and had places where they had rates of 60%. So what can we learn from the countries with lower rates, but also within countries from areas that have low rates? Just on why has Italy's Caesarean section rate reduced so much? So it's decreased from a peak of 38% in 2009 to just under 30% in 2024. So see, these are some of the, I know, real things that have happened. Some of these are suggested reasons that I haven't looked into verifying with data or anything like that. But there was an advocacy movement, I think. One of the things they called it was the multidisciplinary partnership. So women politicians and advocates and health stakeholders joined together and campaigned with the media to raise public awareness about the high Caesarean section rate and to put political pressure to reverse the trend of what would sometimes be called hyper-medicalised childbirth. This then seems to have led to national and regional health policy changes, where they implemented stricter clinical guidance about when a Caesarean section was necessary, discouraging scheduling of elective Caesarean sections without explicit medical justification. It also led to regional health systems changing the financial reimbursement mechanisms. So they moved from having a situation where there was almost double the payment for a Caesarean section as there was for vaginal delivery to having more uniform or closer payments. And then in terms of obstetric culture, medical centres placed stronger emphasis on managing delayed labour again, possibly related to the policy changes that were happening and being brought into practice. That also had a knock-on effect, it seems, with targeted intervention or education. Antenatal classes, greater informing of women who were pregnant as to their options and the different processes that were involved, which had been, I think, a little bit deficient before that. And then looking just for a few minutes at England, because as I mentioned, it's a greatly increasing caesarean section rate, especially in recent years. So it had, like ourselves, a rate of about 25% in 2010, and then less than 10 years later, it gradually increased to 29%. But then after that, in those few years, it went to 31%, 33%, 35%. In 2022, it went to 39%, up 4 percentage points. It's more than 10% increase in 1 year. 41, 44, 45, and maybe 47, 2026. So they had that kind of exponential increase where the size of the rate is actually leading to even more increase. And that was observed, this kind of gradually increasing to rapidly increasing trend for the planned caesarean sections and the emergency caesarean section. So it wasn't just on one side of that dichotomy. Now it was more pronounced for planned caesarean sections. It went from 10% in 2010 to 20%, so doubled over those 15 years, whereas emergency caesarean sections went from 15 to 24. So still more emergency caesarean sections, but not much of a difference. Why is that the case? More complexity is one of the suggestions. There's been a rise in maternal age, pre-existing health conditions, diabetes, hypertension, and obesity. Again, I don't think it would explain a rapidly increasing rate over the last 5 or 6 years. It's not like these factors have suddenly shifted hugely in that shorter period of time, but maybe the longer term trend would be associated with that. Improved monitoring and safety, so better able to detect when there's deteriorating situations and make interventions. Maternal choice, so you're aware that more women are proactively opting for planned caesarean section for various range of reasons in terms of preventing pain, managing anxiety and fear. And then obviously if the reality is that the vast majority of women who had a previous caesarean section will deliver their next child by caesarean section, then obviously as more caesarean sections happen, it's a self-fulfilling prophecy that it will accelerate the increase. I think the last two are very important, and Richard mentioned this earlier, the Ockenden reviews. They've been very high profile in the UK, and in 2022, at the start of the year, there would have been BBC panorama programs about this as well. That was released in their first report, and that really heightened awareness of the deficiencies that in care in some examples that they reported on. And that may have influenced maternal choices. If you're reading or hearing about this in the news, that terrible things that happen and babies have died. And if you're pregnant, you're thinking, I need to have a safe delivery. And it also affects staff in terms of, their concerns about risks and maybe risk averse and having to maybe, opt for a safer option in terms of reducing risk of death. And at the same time, during 2021, the committees that were overseeing governance in terms of targets in the health services in the NHS were considering that they should avoid this situation of having a target of a 20% or whatever percentage target for caesarean sections. And they decided that they were going to stop doing that, so that maternity units didn't have to have a target of a certain percentage. And they formalised that in early 2022. And of course, 2022 is the year where you had a 4 percentage point increase then in caesarean section. So I think those two factors are very relevant. So back home then in Ireland, just the story of our births. Now these are based on hospital births. 99.5% of our births are in hospitals, so it's not exactly a complete picture, but quite close. So we can see the increase in the total number of births. Happy days before the recession, and then gradually it leveled off and has decreased since, has consistently decreased since, except after lengthy lockdowns in 2020, does give rise to more babies. Then we can see the total births by caesarean section was increasing, reached 20,000, and has more or less stayed stable at 20,000 all the way through with a little bit of an increase. And obviously everybody knows in the room, that's just the total number of caesarean sections out of the total number of births. So one is changing, one is going down, the other is relatively stable. So that means that the rate, the percentage of births by caesarean section have been increasing. So we can see the elective is the first curved line there, and on top of it is the emergency section. So it's 25% back in 2005. Very slow increase going on for a number of years after that. And then the increase starts accelerating a little bit. Has continued like that since then. So in 2025, based on the hospital inpatient inquiry data, 24% of the births were by elective C-section, another 19% were by emergency. So you can see that means that there's been more than a doubling of elective C-sections and a smaller increase in emergency C-sections. So now we got the situation where most of our caesarean sections are elective, whereas in the UK or in England, you can see that they're still mostly emergencies. So one of the thoughts I had yesterday at 11 o'clock at night when I should have been putting out the bins was, I wonder if there's been a change in costs associated with this. And I'm not a health economist, so it took me a couple of hours to try to apply these costings. So when a woman is giving birth in a hospital, she's an inpatient, and the main purpose of HIPE, this hospital inpatient inquiry, is to reimburse hospitals for the care that they provide to their patients. So they allocate the inpatient admission to a grouping, a diagnosis-related group, and there's costs then reimbursed to the hospital on the basis of that. So that can range from about €4,000 up to about €13,000. So the group, I'm looking here at 2005 to 2025 and applying the costs of these different DRGs, as they're called. So caesarean section where there's major complications is the bottom here. It's very, very rare, it's a small number. Less rare in 2025, €13,000 is the cost associated with that admission. You can see a big increase in the intermediate level complications with caesarean sections, and very little or no increase in the number of minor complications caesarean sections. In here, then we have some of the operative deliveries, vaginal delivery, but requiring the operating room to be used. Then we have vaginal deliveries where there's major complications. There's been an increase in those. Big decrease in the intermediate complications, the number of those, and an increase in the number of minor complicated vaginal deliveries. So all of these have different costings, and I expected there to be an overall increase in the cost of deliveries as a result of more and more caesarean sections. But in fact, for almost the same number of births, so 52,000, the overall cost was €301 million in 2005. Now it's 2026 prices at €340 million in 2025. There's a big increase in the cost of caesarean sections because there's a lot more of them, and a big decrease in the vaginal delivery costs because of this reduction in intermediate complications. So I don't know, maybe this is a way of reflecting that some of the complications that used to happen during a vaginal delivery are now removed from those and are happening as caesarean sections of lower level of complication. So per woman, for each woman delivered in 2005, the cost was 5,800 and it was 6,400 in 2025, just 10% higher. Also, the average length of stay, I expected that to go up, but in fact it was 3.8 days in 2005, it's 3.6 days in 2025. So not much, slight reduction there. Another thing that's important, I mentioned variation a couple of times already, is to look within your country and look here. We have the Irish Maternity Indicator System, which allows with these funnel plots to give a sense of the overall rate in the horizontal green line there, 40.6% in 2024. And then kind of the dashed curves are kind of indicating, well, you'd expect, almost all units to be within that range. And we can see there is some what we call extra variation. So we have a unit, one of the smaller units, the smaller ones delivering this, the number of women that are delivered, have babies in these hospitals. So there's a range there from one having almost 50% caesarean section and another having less, about a third caesarean section. Here, the larger hospitals, then there's an outlier here as well with the National Maternity Hospital, traditionally having a lower than average caesarean section rate. So it's important to look at this variation and kind of understand What are the mechanisms? What is it about? Is it the patient profile? Is it the practices within the hospital that explain this variation? Just wanted to, and it was mentioned earlier as well, so it's interesting to me that, you know, previous caesarean section impacts on a subsequent delivery and the complications associated with it. And one of them was the placenta accreta spectrum. I looked at the hospital inpatient inquiry data, and it's quite mixed, and I think there's trouble or difficulty. I think there's been a change in the definition, as Mike Robson mentioned. So the recording of it is quite difficult, it seems. So I kind of grouped it to a higher level, essentially to see whether that was just being misdiagnosed sometimes or misrecorded. And you can see the risk has been increasing from about 0.8% to just over 1.2%. But not very striking in terms of that. But again, I think there are issues in the recording of that. Much less common, just to note that it's per thousand here, not percent. So it's 0.3 per thousand, so 1 in 3,000 women having a peripartum hysterectomy. And now it's about 0.5 per thousand, so 1 in every 2,000 women have a peripartum hysterectomy. And again, almost all of these are associated with previous caesarean section, placental accreta spectrum. Just as the last part of my presentation, I just want to talk about, you know, factors associated with caesarean section and how the data can let you down. You know, you might look and say, well, aren't women having their babies later? Maybe that helps explain some of the caesarean section rates across countries. So here's a chart that illustrates that for EU countries, and you can see there's variation from about 26 being the average age for a first baby, for a woman having a first baby, up to 33 or 34. When you map that in with their caesarean section rate, you get a chart like this, which essentially looks like what you'd find if you drop a load of beads on the floor. So it's very hard to see if there's any correlation. It's very minor and negative, so it seems to be going down. But you know, if you take out that outlier of Cyprus, 62%, it's a little bit more like it's going down, as in the older the woman having their first baby, the higher the lower the caesarean section rate. So essentially, older is associated with less caesarean section. So it's not really showing any pattern. The number of women, the number of children that women are having is generally reducing in many countries. And here's a snapshot of that across countries in the EU. So varying from Malta, where it's just over the 1, to up to 1.8 in France. And again, doing the same thing of just at a high level, does that seem to be associated or correlated with the caesarean section rate? Get a correlation that's as close to zero as you can create. So at that level, the data doesn't really tell you a picture or tell you the story. What about body mass index? So our colleagues in Europe, Peristat, are very good at collecting key indicators across countries and over time. Unfortunately, we don't have a graph for Ireland here, but we have Northern Ireland. But you can see the green is the percentage of women giving birth who are in the healthy BMI category. And you can see it's going down in every country, sometimes quite sharply, down to 40% in Northern Ireland. And you can see obviously the increases are coming in overweight, but especially in the obese category, it's often the more steep increasing group. So this is an example of looking at that with colleagues, Diana and Mary, who's in the audience, and with Joy, at how do we really understand better what's happening in our hospitals in our countries, where we can look at the data, hopefully, from electronic health records, even though it's a time-consuming business to get the quality of the data up to which you could feel you can rely on these kind of analysis. But we did this a couple of years ago, looking at 34,000 women who gave birth in Cork University Maternity Hospital during that 5-year period. Caesarean section rate was 36.5%. First, just simply looking at maternal age. Now, there weren't very many women in this over 45-year age group, which you could see 75% of them had a caesarean section. But the shift over time has been for more women to be in the, rather than in the mid-30s into their early 40s. So the profile of women has becoming older, and obviously if they're higher caesarean section, then that does gradually increase the caesarean section rate overall. Kept the same scales up to 80%. So here's parity, first-time mothers, given birth once before, twice before, at least 3 times before. So there is a trend, but it's not very striking. Yeah, then we have BMI. So again, on the same scale, it doesn't look very striking, but you can see it's a graded association. About 30% cesarean section, up to 35, 40, or to something nearly 50 across different categories. And again, the benefit of being able to split up the obesity group into class 1, 2, and 3. So just to end, we've got a couple of busy slides because you might be disappointed there weren't enough percentages or numbers. There's too many charts. So you're aware of many of you would be of the 10 group classification. So we did that with those data. So again, highlighting the large groups that make up a lot of the women who are giving birth, or the women who've had a baby or haven't had a baby before, they're having a single baby. It's at term, they're having induction or cesarean section. That's 20% of the group. 45% has a cesarean section, 9% is the contribution that makes to the overall rate. So 1/4 of the cesarean sections are coming from that one group. And the power of it really is that we can then put those factors all together. So this is just an extract from a detailed table saying, well, is it age, is it parity, is it BMI, is it just what group the women are in? Because they're all connected. The older a woman is, it changes which group she's in, what parity she has, what BMI she has. And what this is telling us is essentially there is a graded association still with age. So less risk of a cesarean section if you're younger than if you're in their 30s, higher if you're in your 40s. At the same time, if you've had one baby before and you're having your second or your third or more, you're less likely to have a cesarean section. A graded association with BMI. The higher your BMI, the higher your risk of a cesarean section. And that's above and beyond being what 10 group classification category you're in. Okay, thank you very much.